Hey everyone, it's John with MP Board Review. This is my third attempt at trying to make this video, interrupted by kids, dogs, mosquito spraying people, telephone calls. So we'll try this again. Hey everyone, so it's been a crazy past couple of weeks, as all you know. I hope you all are doing safe and well. I'm doing safe and well. My family, my hospital, and all my friends are as well. But with Prometric not doing testing right now, this is a great time to study. And I figured let's go ahead and do some short study videos on some questions and rationales, as that seems to be what you guys tend to like. So since I ran out of Francis questions, we're going to go ahead and go to another source. And this is one that I bought back in last year when I was getting ready to test. That is this one over here, in case you guys are interested. This is from Mometrics. It's basically, this resource is only exam questions and rationales. There's about 200 questions with the rationales in the back of the book. Retail price for this is 40 odd bucks. On the Kindle it's only 10, which is a kind of a steal, which I like. So I used it quite a bit when I was studying, just going through those and getting an idea of where my weak areas were. We will not be going through this entire book. I will be selecting certain questions for those people who are concerned about fair use. This is fair use because 1, it's for educational purposes. 2, I'm not showing the entire book. And 3, there is no copyright. So no copyright for them to claim. Again, I'm not going to go through the whole book because that's not fair to the company that put this out, but I'm just going to go through their questions, give my own version of my rationale, and this, of course, it's in concert. I've read their rationale, and I'm just explaining it in my way. Not quite so technical, but hopefully easy to digest. All right, so let's get into it, guys. First one is going to be question number 1. Patients with severe nausea and vomiting not associated with pain are more risk for. So this is your gastroenteritis, guys, not like your appendicitis or cholecystitis or other diseases that would cause severe nausea and vomiting. So let's take a look at our choices. We have hyperkalemia, hypokalemia, hypercalcemia, and hypocalcemia. So it's either going to be, so looking at these questions, we either know it's going to be a high one or a low one, and we know that's either going to be potassium or calcium. So if people are vomiting, they're vomiting up stomach acids. What kind of stuff are in stomach acids? Well, we have our hydrochloric acid. We also have potassium chloride and sodium chloride. So those tend to be lost when we vomit. So we know that it's not going to be calcium, so we can cut those two off. And is it going to be hyper or hypo? So again, when we vomit, we lose potassium chloride. So we're going to be hypokalemic. So the correct answer is B. And again, the normal levels for potassium, as I'm sure you all are aware of, this is a very classic nurse question, is normal potassium levels are 3.5 to 5. Severely low is less than 2.5. What do we see when it's severely low? We see lots of PVCs and ventricular ectopy on the telemetry. What do we see when it's greater than 5.0? We see tall peaked T waves on our EKG, and high levels will put you at risk for having arrhythmias as well. In fact, just having plain old ventricular standstill, ventricular fibrillation. So remember that hyperkalemia leads to ventricular fibrillation and asystole. Hypokalemia leads to ventricular ectopy and VT. All right, that's my little extra. Let's see here. Next one that was interesting to me. Okay, number 5. A 26-year-old male comes to the emergency department complaining of purulent urethral discharge and urinary frequency and burning with increasing severity over the past 3 days. During his assessment, he admits to an encounter with a prostitute 7 days earlier. So we're automatically thinking STD. They took a gram stain and it showed the presence of gram-positive bacteria, but we do not have culture and sensitivity because it takes 3 to 5 days for culture and sensitivity to come back. So as the nurse practitioner in the emergency department, what do you do? So the choices are: wait for the culture and sensitivity results before prescribing treatment. B, prescribing cefotaxime, I can't pronounce this crap, cefotaxime intramuscularly and azithromycin by mouth in single doses. C, prescribing ciprofloxacin PO in a single dose. D, prescribing cefotaxime intravenously, daily until symptoms subside, and then cefixamine daily for 1 week. Okay, so this question tests several things. All right. First of all, it tests your knowledge of how infectious disease works in the hospital. So we have to ask ourselves, what is the most common type of organism that causes STDs? And those are gram-negative bacteria. So chlamydia, gonorrhea, syphilis, they're all gram-negative. It doesn't matter which one it is, they're all gram-negative. Okay? So we're looking for gram-negative antibiotics. So when we know this, we know that the first one, A, waiting for culture and sensitivity, is not the right answer because, one, it takes 3 to 5 days for that to come back. So what do? Are you going to let this guy go out in the wild, spread his wild oats, and continue to give other people chlamydia or gonorrhea or syphilis? No, we're not. So we have to treat this guy. We can't allow him to sow his wild oats. So A is incorrect. Then we have our antibiotic question. So do B prescribe cefotaxime, which is a what? Cephalosporin. Let's look at the list of cephalosporins. There are a lot. We have 5 generations of cephalosporins. Now, for people that, and I know that you're out there, people that are not feeling comfortable with antibiotics, keep this in mind. Cephalosporins cover both gram-negative and gram-positive. Okay? There are generations, 1, 2, 3, 4, 5. Okay? As you go up in the generation, it covers less and less gram-positive and more gram-negative. Okay? So first generation will cover both gram-positive and gram-negative. Second, less gram-positives, more gram-negatives. Third generation, and as we go down, these are more, focusing more on gram-negative stuff. There are certain cephalosporins that do better with certain bacteria than others, but you don't need to know that. Okay, just keep in mind that cephalosporins cover both gram-positive and gram-negative, but as we go up through the generations, it tends to be more gram-negative and less gram-positive. Okay, so the antibiotic that they recommended that we consider was a first generation cephalosporin. Where are you? There are just so dang many. I saw it there. I have to do a search. There it is. There it is. Cefotaxime. Okay, that's a first generation. So we look at this. It has activity against Proteus, E. coli, Klebsiella. All right, so that looks good. And so that will cover against our STDs. And then we also give azithromycin, which is a macrolide. Macrolides also cover gram-positive and gram-negative, okay, especially trich and gonorrhea, okay. And it is a recommended treatment for STDs. So we need to consider that one. Next one is C, prescribing Cipro in a PO dose. This is one of those questions where it is not incorrect to give Cipro, but it is not the best answer. Cipro also covers gram-negative bacteria. It would probably also cover the STD. However, it is not the best because remember we're trying to stay away from fluoroquinolones due to side effects. So we only give Cipro if there's no other choice. So if this guy was allergic to these, we would consider Cipro. And then last one, prescribing the I can't pronounce that, I'm sorry guys. Cefatrizine intravenously daily until symptoms subside for 1 week. Okay, is that economically feasible? Are we going to trust this guy to come into the hospital every day for how long? Probably about 3 days before we start seeing results from his pee-pee. So we're going to have him come on into the hospital every day for 3 days to give him an IV antibiotic and then hope he comes back. And then we're going to give him a different cephalosporin daily for a week. That doesn't sound very economically feasible. So again, when we look through this, we know we can get rid of the culture one, and we can get rid of the IV one because this is an outpatient, see him, send him home kind of thing. Okay, so again, the answer is going to be B, prescribing the cephalosporin and the azithromycin together. They both have gram-negative properties. They both work well against STDs because of the gram-negative properties. Again, Cipro isn't incorrect, but it is not the best answer because we're trying to stay away from fluoroquinolones, and that would be our second choice, but the best choice would be these two guys right there. Okay? Pulsus paradoxus. Okay, and there's a formatting issue. I'll go through this. But abnormal pulsus paradoxus is characterized by systolic blood pressure of, it should be less than 5 millimeters, not 5 pounds, millimeters, of mercury higher than inhalation versus exhalation. Systolic blood pressure less than 5 millimeters, lower during inhalation versus exhalation. And then systolic blood pressure greater than 10 for inhalation than exhalation, and systolic blood pressure greater than 10 lower during inhalation than exhalation. Okay, so this tests you on, do you know what pulsus paradoxus is? Okay, so let's go back to that. What is pulsus paradoxus? So pulsus paradoxus is the change in blood pressure that you have when you have a cardiac tamponade. So what is a cardiac tamponade? This is your heart. This is the lining surrounding your heart called the pericardium. The pericardium creates a liquid to lubricate the heart. Okay, it's constantly churning it out. So it churns it out and reabsorbs it, basically providing lubrication to the heart so it doesn't, like I tell my patients, so it doesn't get stuck on anything, and so the heart can flow freely. There are certain conditions that will cause the pericardium to produce an excess of fluid. The pericardium can only stretch out so far. It is a fibrous sac. So as that sac fills more and more with fluid, you can just see this balloon getting larger and larger until, because it's fibrous, it can't get any larger. Now, that sac can theoretically get larger if this is a slow process. So your people with pericardial effusions from, let's say, end-stage renal failure is a big one, where it's just this slow accumulation. You can get quite a large sac without tamponade, okay? That does happen. I've seen people get like 1 liter, sometimes up to 2 liters of fluid off with no tamponade because it was a very slow grower. But if it becomes acute, if it accumulates quickly, for example, if someone has a AFib ablation and they perf it, they have this device where they sort of sear the electrical pathways to prevent AFib or aflutter. Sometimes that will perf through the wall of the atrium, and then you can get blood accumulating outside of the heart very quickly into the pericardium. That can cause a tamponade. Okay, so this pressure will, after it expands out to its limit, the internal pressure inside the pericardium goes up, and the pressure pushes on the wall of the heart to the point where the right heart can no longer fill with blood, and then you go into shock. What kind of shock is this? Let's see. This is obstructive shock. All right, and I like this little picture here. So you have to think of the body. You know, we have the left ventricle pushing blood out to the body. It comes back and it sits in the IVC and then dumps into the right ventricle. If the right ventricle cannot fill, you can see how this right ventricle is much smaller than this right ventricle over here. If the right ventricle cannot fill, with every stroke, less and less blood goes out to the lung. Less and less blood returns from the lung to the LV, and we go into this spiral where we are getting less and less output. So this is obstructive cardiogenic shock. Okay, how do we fix it? We tap it. They put a needle. We go up through the substernum. We put a needle into that sac, put a little catheter in there, and it drains right out. And then everything takes off and we're good. And we usually leave that drain in there for a day or two to make sure that everything is healed up, and then we let it go. If it does not heal up, then we look at alternative means, such as what we call a pericardial window, where the thoracic surgeon will go in there and basically make a hole in the bottom of the pericardium to allow that fluid just to dump out into the thoracic cavity where it'll be reabsorbed. Okay, so now that I got all the pathophysiology, let's talk about pulsus paradoxus. So as we breathe in, so our lungs expand. So we take a deep breath in, our lungs expand. And what happens when our lungs expand? Our lungs fill up with volume and it pushes pressure into the mediastinum. It pushes pressure onto the sac of the heart. Normally this isn't a big deal. But if this is filled with fluid and we take a deep breath in, we're going to have more pressure pushing into that right ventricle, and then our blood pressure will do what? It will drop, because there's going to be less and less filling of that right ventricle, less and less blood to get to the left ventricle to be pushed out to cause our blood pressure. So we know that from this, we know that we're going to have a lower blood pressure when we breathe in. And then, of course, the final question is how much? Is it going to be 5 or 10 millimeters? By definition, it is 10 millimeters. So when we take a deep breath in, we should see a drop of pressure, blood pressure, by 10 millimeters or greater as we take a deep breath in, as that's pushing pressure on our pericardium and not allowing volume to get to our lungs and into our left ventricle to be pushed out to get pressure. All right. Next one. Using the rifle criteria for classifying increasing renal failure, the 62-year-old patient with an increase of serum creatinine of 200% or a decrease in GFR of greater than 50% with a urine output of less than 0.5 per mil per kilo per hour over 12 hours is classified as what? A, loss, B, risk, C, injury, D, failure. All right, so rifle criteria is something that this is underlined, that you must know for the test, okay? I know more, I know in the hospital, I just, typically before I took my exam, I basically looked at the creatinine. Oh, the creatinine is going up. The creatinine is 1.5. Well, that's chronic kidney disease stage 2 or 3. As soon as it goes up to 2.0, I say, oh, that's stage 4. And when I goes to 3, I go, oh, it's chronic kidney disease stage 5. And when it's like 6, 7, oh, they're end stage. That's not a very scientific way of looking at this, and this is not what the test wants. Okay, so they want the rifle criteria, which not a lot of people are familiar with. So let's go through rifle real quick. This is a nice outline I found online. So we look at risk, injury, failure, loss, and stage, rifle. Okay, and the numbers you need to know, I would know the urine output criteria because I find it easier to remember that way. So risk, if the ICU nurses out there, that we always look for what for urine output. We should see 1 milliliter per kilo per hour, or thereabouts. So when your urine output is less than half a milliliter per kilo per hour for just 6 hours, they're at risk. So you're doing your eyes and nose and you see that the urine is slacked off for 6 hours. You alert the doc, hey, we're getting into trouble, because they're at risk, and they may give fluids, they may adjust their pressures, they may do whatever they need to do to get that urine output up. Okay, so that is risk. We start getting to the and on the opposite side, the creatinine is increased by 1.5. So you have to look at the baseline creatinine. So let's say we have a 30-year-old trauma patient who came in. We know from previous physicals exams that their creatinine is 0.8. So an increase of 1.5 would make it, what, 1.2. So if we went from 0.8 to 1.2, that is a risk. Okay, they're at risk for developing kidney injury. If we reverse that, their kidneys will not be injured. Okay. Next one down, urine output less than 0.5 per millimeter per kilo per hour of 12 hours. So this, so it goes 6, 12, and here we go 24 for the next one. That's just how I remember it. So 6 hours is risk, 12 hours is injury. So now we're not getting enough perfusion in there for 12 hours. Now the little nephrons are starting to die. Okay, we're not getting enough blood flow or volume into the kidneys. Their creatinine is now rising. So that guy with the baseline creatinine of 0.8 is now 1.6. And this, is starting to raise some eyebrows where I think we're getting in a little bit of trouble here. Again, this is where intervention needs to be taken care of. Failure is where we're seeing oliguria or anuria, meaning no urine output for 12 hours, or we're seeing decreased urine output of 0.3 mils per kilo per hour for 24 hours. So either very low output for 24 hours or no urine output for 12 hours. We'll see our creatinine rise to 3 times baseline. So our 0.8 example is now 2.4. Or creatinine of greater than 4 That's where we're starting to get into failure. You can still recover from this, but it's getting pretty bad. And then loss is where we have persistent acute renal failure or complete loss of renal function for greater than 4 weeks, and then below that is I'm making nothing. Okay? So loss would be your people with that consistently elevated creatinine, even though they are making some urine. End stage is no PPs. Okay, so again, this is how I remember it. Just remember the numbers. 6, 12, 24. Okay, so it's just multiples. So 6 times 2 is 12. 12 times 2 is 24. Risk, injury, failure. Creatinine, 1.5, 2, 3. So 1, 2, 3. 6, 12, 24. That's how you remember the rifle criteria. So let's look at this question again. Using the rifle criteria, guy with increased creatinine of 200% or decrease of GFR of 50% with urine output of 0.5 per kilo per hour over 12 hours. Okay, so we talked about this. RIF, because 12. So it's not risk, because risk is 6. It's not failure, because that's 24. We are at injury phase, because we had 2 times baseline, 200%, and less than 0.5 per mil per kilo per hour over 12 hours. So that is that second one. So 6, 12, 24. 6, 12, 24. This is going to be our injury patient. Okay. And let's see. Let's do one more. Actually, let's do 2 more. I'm sorry. Let's do 2 more. So I like this one. Which of the following is an example of dementia-associated condition resulting from an environmental cause? AIDS, Parkinson's, Huntington's, Alzheimer's. Okay, so we're looking, the keyword is environmental, because all of these are dementia. All these things can cause dementia: Alzheimer's, Huntington's, Parkinson's, AIDS. The Alzheimer's, I know some people say, oh, aluminum can cause it. It's more genetic because there are genetic markers for Alzheimer's. Parkinson's, again, genetic. Huntington's I'm not as familiar with, but again, that's more of a organic disease. AIDS is something you get from the environment. It is a disease that can be caught, and that is an environmental cause. Okay, and then this last one, this one is very important for people, especially in the emergency department. On assessment, the nurse practitioner observes an 82-year-old patient has bruises on both forearms and her face. Patient admits that her daughter sometimes gets angry and hits her but feels terrible afterwards. Patient begs the NP to forget about it. The patient should A, take no action, B, report the abuse, C, warn the daughter not to repeat the abuse, or D, refer the patient and daughter for counseling. Okay, so Barkley talks in his review lectures about reportable conditions. Okay, we know about the STDs, but there are also abuse. Okay, so the ones that you have to report are elder abuse and child abuse. Okay, this is elder abuse because this lady lives with her daughter and her daughter smacks the crap out of her. So that's elder abuse and is reportable. If it's a child, 8-year-old child that gets smacked, that's child abuse. If it is husband and wife, that is not reportable because that is a relationship. Okay, there is no, how did Barkley put it? You have chosen to be in that relationship and you can get out of that relationship. You are free to go. You make the choice to be there. That is not a reportable offense. I know that is not politically kosher a lot of times, and a lot of people disagree with it. Yes. But in the eyes of the law, this is how it is reported. Okay? So you cannot report like boyfriend, girlfriend smacking each other. You cannot report husband and wife smacking each other. But, elder abuse, someone over the age of 65, and child abuse, less than 18, are reportable. So that is something you must remember as well. Okay, I think that will end this section, guys. I'll see if I can get another one more of these short videos out for you guys to review in the car or whenever you got a free moment. Thank you very much. I'll talk to you guys next time.